Very good afternoon to everyone, and I thank UPSOS at the outset to give me this opportunity to speak on OCTA. Why do I always prefer to speak on OCTA? Because I feel that this is the underdog of the retinal investigations. It's a beautiful investigative modality, just that we don't understand why to use it and when to use it. So I'll be just going about through some diseases. So this is a diabetic retinopathy slide, and what we can see, the red arrows, these show microaneurysms. So this is a patient with which, when seen clinically, we couldn't see any signs of diabetic retinopathy. But as soon as you do an OCTA, you can see that these are CNP areas, these are some microaneurysms present. So clearly this patient has mild NPDR. And now our treatment course would change. Then you very beautifully you can document the NVDs and NVEs. You do not need to inject any sort of dye to do that. This is a non-invasive modality. So similarly, in this image, if you focus on the superficial and deep scans, which I'll zoom now, you can see how beautifully neovascularization elsewhere has been documented. How do you identify that this is a new vessel? You just observe the caliber of the vessel. It becomes slightly broader, wider. You can see CNP around that. And moreover, the fluorescence also increases. So the purpose of putting these two images are that if you do an FFA, you'll always study just the superficial layer. You won't know what is happening in the deeper layer, in the outer layer, even in the choriocapillaries. And with an OCTA, you can study the pathology going in all the layers. This will help you in treating the patient, which I'll explain in the coming slides. So this slide shows that normally also in choroid there are flow voids. But what happens in diabetics? These all coalesce and become slightly larger. So coming on to vein occlusion, this was a patient of mine who presented with vein occlusion. So when I did an OCTA of this woman, so this is the image of a superficial layer, which you will also see on the FFA. But now notice that as you are going deeper and outer, the amount of non-perfusion increases. So this shows that this patient has an ischemic insult, not a non-ischemic insult. You can also quantify this, that what is the vessel density there, how much is the amount of perfusion present, which can be done in all the layers. Now, why do you need to do this sort of quantification? This is for the treatment purpose only. So this was what was before injection. After injection, the entire image changed. Now I'll come to the importance of quantification. So on the left is pre-injection, on the right is post-injection. So if you notice the central part, it had a vessel density of 36, which increased to 44. Similarly, in the entire, all images, all the layers, these values are increasing. So you can counsel the patient also, there is some reperfusion which is happening, which you cannot do with an FFA or an OCT. And again, this is a non-invasive modality. So this was a rare case of a triple cilioretinal artery sparing CRO. You can see that the entire macula is non-perfused. After the treatment of the patient's cardiac illness, you can see that how beautifully the entire retina is now reperfused. Similarly, this is a case of old STBRVO. Had I not done this OCTA, I wouldn't have gone for an injection because the OCT doesn't show any sort of macular edema. But on OCTA, you can clearly notice the new vessels developing. So just because of this, I will go for an injection of this patient. In dry AMD per se, there's not much role of OCTA, but yes, in wet AMD. So this case shows clearly that there are huge geographic atrophy scars. But if you notice the superficial and deep layer, which I'll zoom now, so there's something going on over here. A polyp-like structure is developing, which is encroaching the foveal avascular zone. And just for this, I'm going to go for an injection. And OCTA is very useful in differentiating type 1 from type 2. So this is a type 1 CNV, where you can see that superficial area is fine. However, CNV net develops in the deeper, in the outer, and the choriocapillaries. Whereas in this image, this CNV net and non-perfusion develops from the superficial to the deeper, to the outer. This is not a CNP area. Rather, this is just a masking effect because of the fluid present intraretinally. There are huge types of, various types of CNV nets, which you need to know. This has some prognostic value as well attached with it. So this is my final case, and this is a young girl having choroidal osteoma with CNV. This is again a published case. So this CNV net can be documented beautifully with an OCTA. And this girl was injected. After 6 weeks, some regression was noted, but not a lot. The girl was re-injected again. And now you can see that in the outer layer, how beautifully the net is regressing. So this regression of CNV net documentation is also important because many a times with injections, these nets regress and you actually treat this. You cannot document this with FFA or an OCT. So my take-home message is that it is a non-invasive modality. It shows beautifully the retinal and choroidal architecture. It is very helpful in detecting a preclinical disease, which no other modality offers till now. It is a very good patient education tool, and it helps in monitoring the disease progression and observe the prognostic value of the condition. Thank you for your patient listening.
Very nice. I think one question. One advantage of OCTA over OCT or angiography.
So yes, I always say OCTA cannot replace FFA. Both the modalities are at their own places. But yes, OCTA has an advantage of being non-invasive. So if a patient of hypertension or a kidney disease comes to you, you do not need to inject any dye. You just straight away go for an OCTA and you'll get the entire image, and your treatment can go ahead. However, FFA carries a huge risk of having a reaction, anaphylactic reaction maybe.
Give the floating mic, yeah.
They are both complementary.
I totally agree, sir. FFA cannot replace OCTA. Yeah. Should change. Yes, it becomes mild NPDR. Yes, yes, yes. Definitely, sir. Agreed. Agreed, sir. Thank you. Thank you very much.